Hi, my name is Piazza. I'm an interventional cardiologist from the McGill University Health Center in Montreal, and I also work with the cardiovascular surgeons at the German Heart Center Munich. And here with me today is Professor Ari Peter Kappetein from the Erasmus Medical Center in Rotterdam. And we're going to be discussing all you need to know about transcatheter aortic valve implantation in 2014.
Right. Great. Thank you very much, Nicolo.
So, Peter, let's begin with some issues regarding paravalvular leaks. What are its causes, and how do you see some of the newer devices taking care of this?
So, paravalvular leakage is mainly caused by incorrect sizing and an incorrect valve, in the aortic annulus. So, why is it a concern is also that it may decrease life expectancy of the patient. So I think that the new devices that come on the market have to address this issue. It's not like the mild or moderate paravalvular leakage will have an effect, but especially the moderate or severe paravalvular leakage has an effect on survival. So hopefully with better sizing, but also with new devices that may prevent paravalvular leakage, outcome for the patient will become better.
And how often do we see moderate to severe paravalvular leak?
Yeah, so it depends a little bit on what series you're looking at, and what time frame especially, because people have become better in sizing. So the moderate to severe is decreasing. It used to be perhaps even around 25-30%, and now in newer series, later series, you see it, let's say, in 5%, 10% of the cases, the series. So I think it's already decreasing, but we should further decrease it and try to get up to zero.
Yeah. So that was my next question. Do you think the 5 to 10% that we're seeing, and sometimes 3%, is good enough to bring this technology into younger and lower risk patients, or you really want to abolish the paravalvular leak?
I think you want to abolish it. In surgery, we are used to, let's say, zero paravalvular leakage, and we even go back, when we see it post-op echo, while we're still in the OR, you see some paravalvular leakage, you go back and try to fix it. Because we know it may cause hemolysis in surgery, in surgical paravalvular leakage, but also decrease life expectancy of the patient. So especially when we move towards younger patients, you want to, I guess, try to get as minimal paravalvular leakage as possible.
And the issue about conduction abnormalities and left bundle branch blocks and new pacemaker implantations. Do you think this used to be an unresolved issue, or do you think this was an issue that was important back then and now sort of has, we found the problem and we brought down the rates, or do you think this is an ongoing issue?
Well, again, if we take as gold standard the surgical valve replacement, the pacemaker implantation rate is about 3%, 5%. The maximum, and now we see with these transcatheter heart valve that it may go up to 25-30% even pacemaker implantation rates. The question is, how will it affect the survival of the patient? And it might be that in the elderly patients it may not really play a role there. But again, if you move towards younger patients that have a life ahead of them, it may play a role also there. Complication of pacemakers, you have to replace them, etc. So I think the lower the rate, the better. And again, with better sizing, better positioning of the valve, it has already decreased.
I remember some manuscripts where the rate of left bundle branch block after surgical aortic valve replacement is in the order of about 20-25% sometimes. And there's been several manuscripts that have suggested that those patients who do develop a new left bundle branch block after surgery have an increased sudden cardiac death rate or need for permanent pacemaker implant at 1 year. And of course, these are all-comer surgical cohorts, so mean age of 60, 65. So in those patients, surgery has found that it increases mortality. So it's going to be interesting, as you note, that maybe might not affect these elderly patients, but who knows what's going to happen for these younger and lower risk patients.
So do you think that it may prevent even, or may increase survival if you implant a pacemaker in those type of patients?
Yeah, there was some data published from the Quebec group very recently in circulation. They looked at about 1,500 patients who underwent core valve or Edwards sapien implantation. And they found that in those patients who had a new permanent pacemaker, they had a lower sudden cardiac death rate at 1 year. So it may be that pacemakers are protective with respect to mortality in patients undergoing TAVI in the elderly cohort, but we'll have to see in the intermediate and lower risk patients.
So the difference in rates, pacemaker implantation rate, is not such a big issue, do you think? So between the different devices?
Yeah, there's still some big differences between devices. For instance, the core valve is associated with a permanent pacemaker rate of about 22%. The Edwards Sapien hovers anywhere between 2 and 6%. The Boston Scientific Sadra valve is in the vicinity of 25%. And you have Symetis and Jena valve, who are about 8 to 12%. The predictors of these permanent pacemakers are not completely understood, but some of the things that come up all the time in publications is pre-existing right bundle branch block. Yep. And many of these guys develop left bundle branch block after the procedure, so in essence you're creating a complete heart block, so it makes sense. Pre-existing right bundle branch block is a predictor. The depth of implant. And so there have been attempts to lower the pacemaker rate, but I don't think we've actually demonstrated through clinical practice to lower the pacemaker rate with a particular device yet.
So what other kind of complications are particular for transcatheter heart valves that we don't see in surgical valves?
Vascular complications is one of them, and when you compare surgery versus transcatheter, you always see a higher rate of vascular complications with transcatheter, and that's because it's percutaneous, of course, and we're going through some vessels. But with time, since the introduction of the 25 French core valve and the 24 and 26 French Edwards, and now these going down to 16, 18, 20 French as we hear, the rates of vascular complications have reduced. They were somewhere in the 20-25% range back in 2006, 7, and 8, 9. But more recently, we're still seeing some significant rates of 8 to 15%, which I think is still important. What do you think?
When we think about endocarditis, for example, will that be different? Endocarditis rates or valve thrombosis, or are these different?
Yeah, these are different types of valve failure modalities with surgical bioprosthetic valves. There have been case reports of endocarditis and thrombosis with transcatheter valves. We don't have many large registry cohorts to actually document and follow up these patients and understand exactly what is the incidence and what are the outcomes. We just have case reports up until now, so we really don't know.
No, right. So we need to follow those patients longer, isn't it? I mean, that's an important issue.
Yeah. Peter, I was thinking about we have all of these new devices, and there have been about 8 or 9 transcatheter valves CE marked in Europe. And how do you foresee the penetration of these devices into the market vis-a-vis their costs and reimbursement strategies across Europe? And eventually, what do you think will happen to the cost of these devices as we move forward? And when will that change happen, if it will happen?
Yeah, so I think the costs have to come down if you move towards lower risk patients, because then the competition with surgery will be more difficult in terms of costs. Patients that are at lower risk, surgery is not as expensive in the high risk patient because they are dismissed earlier from the hospital, don't need as many intensive care days, blood usage will be less. So I think the device has to become cheaper to be competitive with surgery in the intermediate risk or low risk patient population. So the device price has to come down. With more competition on the market, you may expect it, but of course the small startup companies also want to get their share and pay their investors back. So they are not the ones that will start lowering the price. So it should come from the big companies that start lowering the price. And when that will happen, nobody knows actually. What you will already see in Europe, that the price is lower than when they were introduced. The core valve and sapien valves have,
So
it's somewhat cheaper now.
What's the cost of a surgical aortic valve, and what's the cost of a transcatheter valve typically?
Yeah, so typically the surgical valve is around 2,500 euros, and in the transcatheter heart valves are in the range of 20,000 euros. So it's almost 10 to 10 times more expensive.
So if you consider that transcatheter valve therapies is a minimally invasive therapy, patients should recover much quicker, they should be discharged less to convalescence homes, lesser stays in the ICU, etc., etc. How low do you think transcatheter valve price needs to go before you can say that it'll be cost neutral, let's say, to surgery?
So I think if the price would go down to, let's say, around 10,000 euros, 8,000 euros, at 1 year follow-up, it will break even, I guess, with surgical valve replacement.
Okay.
There's a long way to go.
Yeah, and what's the current reimbursement strategy in the Netherlands for transcatheter aortic valves, and how does it differ, across Europe with your colleagues?
Yeah, and so in Europe it's very different. We have a DRG code now for transcatheter heart valve implantation in the Netherlands. But for example, what they forgot is that there's also a surgeon involved. So the surgeon doesn't get paid anything anymore. And while a couple of years ago that was still the case. So if a surgeon is involved with, let's say, transapical or subclavian, he cannot even get it reimbursed. The time that he spends in the cath lab, etc. So that's something that has to be corrected in the future, especially when you promote the heart team approach in these type of patients. I think that you have to find a solution for it. So the DRG code in the Netherlands is actually, well, it's okay now. I mean, you don't make a lot of money out of it as a hospital, but you could say you break almost even.
Is there a cutoff as to as many TAVIs you can do, or it's unlimited?
No, there is a cutoff. So you negotiate with your insurance company how many TAVIs you can do per year. Yeah.
Okay. And do you think the reimbursement strategy across Europe has impacted the number of implants across Europe, or the number of implanting centers?
Yes. So you see that the largest number of implants is taking place in Germany, where the reimbursement system is very favorable for TAVI. In Belgium it's very low, and it's a country just south of the Netherlands and not far away. But there the number is low because they don't get reimbursed for TAVI, or very limited number of patients. UK looking very much at cost effectiveness, and so there the reimbursement is not very favorable. So it has a major impact on how many procedures are done per year.
Peter,
so for the new device, because that was the part of the question that you asked, so there will be the smaller startup companies. I think the difficulty for them is now to keep up with the bigger ones, because the big companies will come up with new devices that have improved. And so for the small companies, to improve their device costs a lot of money. And so I think that's a difficult time for them.
Peter, maybe just to wrap up, maybe I'd like to get your opinion on a statement that surgery or surgical aortic valve replacement in the future will be reserved for those patients who have a contraindication to transcatheter aortic valve implantation. Do you think that will be true at some point, and if so, when?
Yeah, so that will not be true. Let me be clear about that. It may be true for the patients that currently get a bioprosthesis. That may happen already, let's say, in 5 to 10 years. But those patients that get mechanical valve prosthesis, I think the durability will play a role in the bioprosthetic transcatheter heart valves as well. And so the durability will be around 10 to 15 years, maybe similar to the bioprosthetic surgical valves. But that means that otherwise you have to put a valve in a valve, and then if that one fails, you have to put a valve in a valve in a valve, and there's a limit to that.
Sure. So let me try to get a yes from you. So what you're saying is that patients who are receiving a surgical bioprosthetic valve, it is foreseeable that in the future, in those patients, that surgery will be indicated for those with a contraindication to TAVI.
That may well be. That may well be. Yeah, but yeah, nobody knows how fast it will occur. But that might be the case. Sure.
Okay.
Good.